Jeev. Now I request Dr. Vinod ARORA to give his presentation on advanced surface ablation, Armageddon.
दे दो भैया. So, Namaskaram. My question I usually start with, which is the most popular refractive surgery nowadays? Any idea? Cataract is the most popular refractive surgery as such. So everybody who's doing cataract is a refractive surgeon. Second comes these cornea-based surgeries. So basically, we know that it started with like RK, AK, PRK, LASIK, interlace, epilasic, SMILE, Contura vision, then advanced surface ablation. These things are evolving gradually and we are getting better and better. So the first corneal refractive surgery was PRK, which was more accurate. It was myopia, hypermetropia and astigmatism were able to correct. The results were stable as compared to RK. Initially there was broad beam lasers, it causes more pain. There was a delayed hearing and scarring was quite common in those cases. Then came LASIK. So it makes the rapid recovery. There is a wow factor, decreased risk of scarring. There was no pain, but flap-related complications were common in these patients like flap strie, buttonholing, debris, epithelial growth, DLK, late trauma, and even ectasia. Of course, these are not very common, but it occurred with flap-related things. Then came femto, which made a very planar flap, thinner flaps, fewer incomplete flap or buttonholing, but some problems still persisted like late trauma and ectasia can occur also. Then came a SMILE, again a very good procedure, but at present there are some limitations. You can't correct a plus number, customized treatment like topo-guided or wavefront not possible, difficulty in low power correction, bitoric or mixed astigmatism cannot be treated, treatment centered on the pupil so causes a lot of coma also. There is no provision for cyclotorsion compensation. There is little decentration of the flap in LASIK causes no effect, while in SMILE it causes high coma aberrations which can persist even up to 6 months. Then what is the indication of advanced surface ablation over LASIK or SMILE? If you've got an irregular astigmatism, if there are chances of FKC, that means a pre-keratoconus condition, if there is a thin cornea, if there is a night vision concern, if there is anterior stomal opacities, some sports which involve like hazardous duty or trauma may be there. And if the patient has gone prior RK or AK, if you want to do customized treatment, and if the patient like RD surgery has been done, filtering bleb, or they deep set eyes, you can't fix a ring on those cases. So advanced surface overscores about on LASIK or SMILE. So what are the contraindications? If there is active herpes zoster, dry eye, glaucoma, irregular astigmatism, uveitis, if there is a cataract or some formation there, and progressive retinal pathology, one should avoid doing any refractive surgery. Then if there is a diabetes mellitus, because it causes a decrease in the contrast sensitivity again, and pregnancy, lactation, rheumatoid arthritis, SLE, abnormal wound healing is there. Then if there are systemic infections like HIV, TB, some drugs, if the patient is on drugs, we have to avoid it. And if there is an antihypertensive, antipsychotic, or Parkinsonism medicine, etc., these cause a lot of dry eye. We should avoid in these cases. So PRK provides the safest system as far as corneal biomechanics is concerned. A lot of paper has been published where it's shown that ASA is probably the safest procedure. And it can be used to correct high myopia also. It can be, C3R can be combined with PRK. Due to lack of time, I'll not go in detail, but it's a topo-guided treatment and we regularize the cornea and make the cornea stiff. What is the basic procedure is putting local drops and then removing epithelium. Then laser is applied and mitomycin is used. Then the bandage contact lens. So it's a very, very simple. Anybody can do on the day one. There's no learning curve as such. It's a very simple procedure. You have to remove epithelium, put laser, put a bandage lens and put medicine. So you don't have to do anything manually yourself. No learning curve, just you have to press a switch. So what were the complications with earlier system? There was a stomal scoring, irregular astigmatism, persistent corneal epithelial defects, recurrent epithelial erosions, and epitheliopathy. These were there, now it's not with the modern system. So how we have improved the results in advanced surface ablation. So preoperatively, careful preoperative checkup, look for blepharitis, dry eye. If there, we have to treat it. Then in the operative, we have to use MMC, which is a game changer. Then contact lens soaked with the AQL is again good. Then mitomycin is a game changer. It is a potent antimicrobial. It inhibits DNA, cellular RNA, and protein synthesis, block keratocytosis. So it prevents anterior stromal scarring. That's changed the whole game. Then again in the postoperative period, we have to avoid overexposure to topical steroids. Oral pain agents are not much better, and avoid aminoglycosides. Improve epithelial regeneration by giving nutritional supplement. If there is a defect, we have to use doxycycline. Avoid UV exposure. It's probably the most important thing. We have to give a very good quality goggles to these patients. So these are the newer technologies which has made advanced surface ablation to come back in the mainstream. This is from Schwind. Then this is from Streamlight, that's Alcon I'm using. It's a trans PRK. The basic difference earlier PTK plus PRK was that it was introducing myopia. There was not a planar removal of the epithelium. Now we are removing epithelium in a wavefront optimized way. There is no refractive component, and whole the procedure is one step. That means you just press the laser, it will take off epithelium, it will clear the number also. You don't require any stop in between. And so far our range has gone even as good as myopia or smile. So all the correction can be done very easily up to 10 diopter. This is a one step. Only thing you have to set the thing, just press the button, it will do everything, removing epithelium, doing the correction, and all you have to do put mitomycin on these cases. And the epithelium is followed by the refraction correction is done. So there is a epi-ablation zone automatically determined by the laser. So we don't waste epithelium as such. We just remove the minimum epithelium that is required. There is an active eye tracker throughout. So as such, the advantages are accelerated healing and visual recovery. By limiting minimum epithelial removal, there is less pain, there is reduced risk of haze by accelerating healing, by smooth surface and better contour, by removing damaged cells and reducing thermal effect. So the drawbacks, the flip side is that it accentuates the importance of epithelial mapping. It causes more heat. It's still not available with premium profile like custom Q or Contura. It has a price tag. We have to use a card for every procedure. So overall, the advantages of are it's a very gentle, it's a no touch, no cut, no incision. It's a safe, more biomechanical preservation of the corneal stability, stress-free, faster treatment, no effect on posterior segment, excellent clinical outcome, reduces dry eye, can be combined with CXL, it's economical, you don't need femtosecond laser or microcartoon. So what are the three things which brought ASA back into the mainstream? It's a better excimer profile, mitomycin C, and better epithelial removal in a wavefront optimized form. Surface ablation is one of the most effective tools in surgical armamentarium of refractive surgeon. It is still underutilized, but it's a very promising and exciting with superior results. I started with LASIK rejects. Earlier I was doing around 5%. Now we have almost 1/3 of patients are getting advanced surface